the video of Mayo Celda.
Thank you very much for the invitation. My name is Maria
Could you hear?
Professor of Neurosurgery at Mayo Clinic and Director of the Wharton Surgical Anatomy Lab. Thank you very much. We are going to discuss today the surgical anatomy. Thank you very much for the invitation. My name is Maria Celda. I'm a Professor of Neurosurgery at Mayo Clinic and Director of the Wharton Surgical Anatomy Lab. Thank you very much. We are going to discuss today the surgical anatomy of the head and neck muscles in this Neuroanatomy series. And we're going to discuss two areas, the areas of head and the area of the neck. And these areas are divided by a line between the inferior aspect of the mandible and the occipital protuberance. And this is the osseous structure, the cranium. Laterally. And if we pay attention to the C1, C2 areas, we can see the C1, C2 or atlantoaxial joint that are just medial to the vertebral artery. And then the vertebral artery, as it ascends through the foramen transversarium, it turns back over the lateral mass of the atlas, over the groove for the vertebral artery. And this is how it turns and hugs the lateral mass of the atlas to become intracranial and intradural. So this is the posterior aspect of the neck, where we can see the occipitocervical junction with C1 and C2, and the segment that is just lateral to the C1, C2 joint, and then the segment that goes around the lateral mass of the atlas in the sulcus arteriosus here to become intradural. This is a detail of that turn of the vertebral artery, and just of note, we're going to see in the cervical vertebrae the anterior portion with the vertebral artery, and then posteriorly the cervical root. So if we go now, we are going to start layer by layer the muscles of the neck region. And here the ear is posterior, and we can see an oblique view of the neck where we have dissected the subcutaneous tissue and the platysma colli. The platysma is a very thin layer of muscle, and we have the fascia that we have removed. If we divide and we elevate this region, then we see the platysma that has been reflected and divided superiorly. And these small branches that are the branches of the facial nerve is the cervical branch of the facial nerve that innervates the platysma colli. We see general anatomy as well. This is the parotid gland, and the submandibular gland, and then we're going to go a little bit in detail through the muscles, but we can see in depth, we can see the common parotid bifurcation, and here, for instance, we can see the vagus nerve. Then looking at the facial nerve, we can see the parotid gland here. The facial nerve travels in between the deep and superficial lobes of the parotid gland. And we see several branches here that go to the musculature of the face. And we want to pay attention. This is the cervical branch that we saw earlier. And we want to pay attention to the marginal mandibular branch. Also, part of the facial nerve that innervates the inferior aspect and the corner of the lip. And this is important, it has an important surgical significance in head and neck surgery that we are going to see. Here we see in depth, in the deeper layer, we see the masseter muscle, we see the buccinator muscle, and then superficial to them, we see the facial muscles that we will again look at it in detail. This is the marginal mandibular branch, and this is the bone of the mandible with the platysma colli that has been reflected. And usually the incision is safer about 2 centimeters below the angle of the mandible to avoid damage of the marginal mandibular branch of the facial nerve. Here we see also important the digastric tendon here, the posterior belly of the digastric, and then we see also the facial artery coming this way, and this is the submandibular gland, and we can see also the carotid, the vagus nerve, and ansa cervicalis, and this is the internal jugular vein and the sternocleidomastoid muscle. So a lot of different and important anatomy that we can see in this picture. But now if we want to go a little bit in detail through the muscles of the neck, we have, and the neck is divided in triangles. And when we look at the triangles of the neck, we have an anterior triangle and a posterior triangle. The anterior triangle and they are both divided by the sternocleidomastoid muscle. The anterior triangle of the neck is located between, or is referenced between the midline, the mandible, and the sternocleidomastoid muscle. In this triangle, we have 2 compartments, the suprahyoid compartment and the infrahyoid compartment. They are both divided by the plane of the hyoid. And then we're going to further divide those. The posterior triangle of the neck is reference between the sternocleidomastoid muscle, the clavicle, and the trapezius muscle. Going more into detail, in the suprahyoid space, we have this space divided by the digastric muscle, anterior and posterior belly, into the submental space that is filled with ganglia, fat, and muscle, and the posterior aspect of the submandibular triangle, in which if we dissect and retract the submandibular gland, we can find the hypoglossal nerve in the vertex of this triangle. In the anterior triangle of the neck, in the infrahyoid compartment, we can divide this by the omohyoid muscle into the muscular triangle, which is located here anteriorly, and the carotid triangle that is located posteriorly. The muscular triangle, we can see here, this is the thyroid cartilage, and we can see the sternohyoid muscle, and laterally the sternothyroid muscle. So these form the muscular compartment, and we can see the carotid triangle, in which we can see the carotid bifurcation. There are many other anatomical structures that are located here, but the main one that gives the name to this triangle is the carotid bifurcation. We can see also in this anatomical picture, we can see the ansa cervicalis here that innervates those muscles as well. And we see the cervical plexus, and then we also see here posteriorly the brachial plexus. This is the internal jugular vein, and this is the carotid artery that are located here. And then we can see also the vagus nerve. Right here posteriorly. This is more of a surgical view of these anatomical structures. So we can see the inferior aspect of the mandible. You can see submandibular gland and the facial artery, and here the nerve, the omohyoid. Here, I'm sorry, this is the muscle, the omohyoid muscle, and then this is the thyroid cartilage. We can see the sternohyoid muscle, the sternothyroid muscle laterally, and here the carotid bifurcation in the carotid triangle, and here we can see when we remove all this musculature and we are in the prevertebral space, we can see the longus-colli muscle, which is located here, and then we can see the carotid bifurcation. Here, the external carotid has been divided, and the nerves that are in this vicinity that of note is that we can see here the 9th cranial nerve. This is the 12th cranial nerve, and this is 10 or the vagus. We can also see the 11th cranial nerve. So this is a region with different delicate and anatomical neurovascular anatomical structures. Well, if we elevate and we divide and elevate the sternocleidomastoid muscle, and we can see better the whole area of the omohyoid muscle. We can see here the brachial plexus, and the brachial plexus located between the anterior scalene muscle, and then posterior we have the middle scalene muscle. We can see very nicely here the brachial plexus. This is the phrenic nerve that goes just over the anterior scalene muscle. So those are important anatomical structures to take into consideration. Also, we have here inferiorly to the omohyoid, we also have the thoracic duct right there in the confluence between the subclavian vein and the internal jugular vein in this location. This is a close-up view of this dissection in which we can clearly see the omohyoid muscle, the sternocleidomastoid muscle that has been retracted as well, and all the venous anatomical structures that are surrounding these muscles of the neck, that are the anterior jugular vein, the external jugular vein, and the internal jugular vein. Here is a detailed view of the thoracic duct and the confluence of the veins in this angle. We can see better the brachial plexus, the anterior scalene muscle, and the middle posterior scalene muscle. This is a picture with the sternum and the clavicle that have been divided, and then we see the subclavian vein very well, and the origin of the anterior jugular vein. We can see also the thyroid gland and the prethyroid muscles that we have divided and retracted here, and how the ansa cervicalis innervates these muscles in the neck. This is a surgical anatomy view from superior to inferior. So this is anterior and this is posterior, where we can see clearly the thoracic duct, and we have a nice view of the anterior scalene muscle and the phrenic nerve over it, with immediately posterior to it we have the brachial plexus. So here is another view of the posterior triangle of the neck. And then we see many of the branches of the cervical plexus. And this is Erb's point, where we can see the confluence of these branches of the cervical plexus. We have the transverse cervical nerve, the supraclavicular nerves here. We also have, this is a posterior view of this point called Erb's point, which is about in the posterior aspect of the sternocleidomastoid muscle, about, you know, it is about, you know, mid-distance from the origin and the other insertion. And then we can see the greater auricular nerve here, and then the supraclavicular nerves as well. We can also see the lesser occipital nerve that comes here posteriorly. And then that's another view laterally of this area of the many branches of the cervical plexus. This is a close-up view of that cervical plexus, and we can also see this is the 11th cranial nerve running also posteriorly, very close to these other nerves from the brachial plexus. We can also see here the branches of the facial nerve coming in between both lobes of the parotid gland. This is a lateral view just to see better the carotid artery that is related anteriorly to the vagus nerve, which is located here, and we have retracted the internal jugular vein. This is another view posteriorly of the vascular structures, the relationship between the branches of the cervical plexus and the carotid bifurcation, and then laterally retracted the internal jugular vein. The posterior cervical region is covered by the trapezius muscle, and we have the superficial layer, the same layer we can see the trapezius, and then here we see the posterior insertion of the sternocleidomastoid muscle, and then the next layer down is the splenius cavities, and here of note we can see the greater occipital and the lesser occipital nerves. Once we divide and dissect the trapezius and the splenius, we are faced with the semispinalis cavities that if it's dissected and retracted laterally, we can see the suboccipital triangle. The reason why this suboccipital triangle is very important is because in the center of this triangle, we have the vertebral artery over the sulcus arteriosus of T1. The boundaries of these are the superior oblique, the inferior oblique muscle, and the posterior rectus muscle, the major here, and the posterior rectus minor muscle, which is here, which is not part of the suboccipital triangle. There's a very rich venous plexus, the suboccipital plexus around the vertebral artery. And if we retract the muscle, we can see very well the vertebral artery in the center. And this is the ramus of C1 that goes really close to the vertebral artery in this segment. Here in one side, we can see it not dissected, and here completely dissected, and we can see the vertebral artery. And then we can also see here the occipital artery that has some anastomosis with the vertebral artery, as well as the deep cervical artery that provides vascularization to all these muscles. This is the greater occipital nerve as it comes from T2. And again, we can see a deep and rich venous plexus around the vertebral artery. And this is the vertebral artery as well. This is a close-up view of the vertebral artery and its anastomosis, which are quite frequent between the muscular branches, and also anastomosis between the occipital artery. And those are important to take into consideration during surgery because they can be damaged and it's a very copious bleeding because it's also coming from the vertebral artery. Here's a dissection down almost to the bone with only some insertions of the muscle left where we can see the spine posteriorly. And here we can see really well C2, that area of C2 with its nerve, the anterior ramus and the posterior ramus that gives the greater occipital nerve. This is a close-up view of the anterior ramus that goes around the vertebral artery in the segment just lateral to the C1, C2 junction, and then this is posteriorly forming the greater occipital. This is a close-up view of the occipito-cervical junction, in which we can see the junction here between the condyle, the occipital condyle, and C1, and then the articulation between C1 and C2 laterally, and the relationship of these with the vertebral artery. Here we have exposed the dura posteriorly, just to show now the neural elements, the cerebellum, and the spinal cord, as well as the arachnoid and the dura mater that has been retracted. Now we're going to start with some notes, journal notes about the facial anatomy. The muscles of the face, there are many muscles. We're going to discuss the most relevant muscles that are in the superficial plane. The one that this is the frontalis belly of the fronto-occipitalis muscle. Has a frontal and an occipital aspect of it, or belly. And then we have the orbicularis oris, the corrugator supercilii, the levators, and then we have the zygomaticus minor and major, and the orbicularis oris right here, the depressor of the angle of the lip as well. And then we can see all the innervation through the little branches of the facial nerve. The temporal branches that go towards the belly, the frontal belly of the fronto-occipitalis muscle, then the branches, the zygomatic branches that go to this area towards the orbicularis oris. This is a frontal view of this anatomy where we can see the orbicularis oculi and oris, zygomaticus major, minor, the depressor, anguli oris, mentalis here, and this is part of the platysma. We can see in a deeper plane, deeper to the branches of the facial nerve, we can see the masseter. We can also see, importantly, this is the superficial temporal artery, the anterior and the posterior branches. We have some deep musculature here in the face that we are looking at, but this is to look at the vascularization of through the facial artery and vein and all their branches. This is a close-up view looking at the anastomosis also between the trigeminal branches of the trigeminal nerve and the facial nerve. Here, the infraorbital nerve anastomosis with some branches of the facial nerve. So this is a view of the temporal area on the right side. This is to explain the layers that form the fascia of around the temporalis muscle So posteriorly, we only have one layer of fascia, but anteriorly, about 2 centimeters posterior to the orbital rim, the fascia divides into two layers, the deep temporalis fascia and the superficial temporalis fascia. In between, we have a 5 path. So the facial nerve branches that go to the frontal belly of the front occipitalis muscle, they go superior to the superficial layer of the fascia. So any dissection that is either interfascial or subfascial dissection is going to protect these branches. So this is a deeper dissection of the muscles, and this is the temporalis muscle, and here is the masseter muscle. We can see the attachment of the masseter muscle to the zygoma. If we remove the masseter muscle, and we also remove part of the mandible, we can see the deeper plane, and we would be inside the infratemporal fossa. We can see the buccinator muscle, and this is the part of the parotid duct that is divided here. So this is a better view of the insertion of the pterygoid muscles into the medial aspect of the mandible. So now going a little bit deeper to the temporalis, to the infratemporal fossa. These are the pterygoid muscles that have been divided and contracted. The internal and the medial and lateral pterygoid muscles, and then we can see in a deeper plane, we can visualize very well the digastric muscle, and then all the muscles that are attached to the styloid process that are in a deeper plane. An important anatomical structure here is to see the carotid artery, the external carotid artery divided into the terminal branches, the internal maxillary artery, and the superficial temporal artery. Here we can see more detail. We see the styloid muscles. And then we can also see the digastric muscle. Here also the branches of the third division of the trigeminal nerve coming out from the valley, which is located here. Then if we divide all these structures and we divide also the buccinator muscle, we have entered into the oral cavity where we can see the muscles that form the tongue and the base of the mouth. Here, as we can see very well, we can see all the way over the bifurcation of the carotid. This is the hypoglossal nerve, and that integrates this anatomy. Here we can see also the lingual nerve and even the terminal branches of these, including the terminal branches of the lingual artery. So this is what I wanted to discuss today. And just to mention that most of these work I performed as a fellow of Dr. Roten in Gainesville many years ago. And this is dedicated also to Dr. Roten, who was a wonderful mentor and brilliant neurosurgeon and very kind human being who we will all remember. And thanks to him and his legacy, we were able to open the surgical anatomy Roten program at Mayo Clinic here, along with, this is the opening, along with his family. So I just wanted to mention this and acknowledge their contributions, and thank you very much for your attention.
I would like to thank the Maria for the detailed explanation of the head and neck anatomy. I think these are the one of the best photos of this area, and I think there is no questions. Professor Kibar, do you want to say anything about what Maria explained? Okay. If there's no questions, we can close the session. Nagiza, do you want to say something about presentations?
Okay, thank you so much. It's a brilliant presentation with detailed anatomy, and I think it is very important for all neurosurgeons, especially who are doing spine, vascular, and skull base, especially anterior anatomy is important for safe procedures, at least of ACDF, and the posterior anatomy for far lateral, extreme lateral approaches, and C1, C2 junction. So that is very detailed. Thank you so much.
Okay. I think we want to see all attendees in the next week. We must check the program for the next week. Next week, we will talk about the craniocervical junction anatomy and vital canal anatomy. And Victor Hugo Perez will be with us, and Jati Patipan. See you next week.
Thank you so much.